Hi everyone, in this video we will teach you how to perform a surgical stabilization of hip luxation by intra-articular reconstruction of the round ligament in the canine model. This technique uses an ultra-high molecular weight polyethylene implant fixed on the acetabulum by a pre-assembled cortical button and on the femur by an interference screw to restore the physiological hip stability and motion. The implant is passed through three bone tunnels. An acetabular tunnel, a first femoral tunnel from the base of the greater trochanter to the fovea capitis, and the second femoral tunnel perpendicular to the first one in a more distal position on the proximal femoral metaphysis. This technique was designed to be performed without an assistant. However, an assistant can help maintain limb position during critical steps like tunnel drilling and implant tensioning. The technique allows treating craniodorsal, caudodorsal, and caudoventral luxations of traumatic origin associated with disruption of the round ligament. It is not indicated in animals with hip dysplasia and not to be used in an infected site. The materials required for this procedure are shown here. The size of the novalic platine implants, the interference screw, and the drill bit is selected according to the animal size based on the manufacturer's recommendation. Apply strict aseptic measures throughout the procedure. With the dog under general anesthesia and placed in lateral recumbency, perform a craniolateral approach to the hip to expose the acetabulum, the femoral head, and the base of the greater trochanter. Resect the remnants of the round ligament from both the femoral head and the acetabulum using bone-holding forceps. Make a small incision caudal to the lateral head of the quadriceps to access the base of the greater trochanter for placement of the drilling guide. Care should be taken to preserve the sciatic nerve. To drill the femoral passage tunnel, anchor the hook of the drilling guide on the round ligament footprint to target the fovea capitis and anchor the guide sleeve at the point of maximum width, a few millimeters distal to the greater trochanter beneath the gluteal insertion. Assess the resulting axis as it may not align with the femoral neck in some animals. An incorrect axis, particularly through the ventral aspect of the neck, increases the risk of fracture and should be corrected at the sleeve level. Drive a threaded K-wire through the guide sleeve until the hook. Then remove the aiming guide while leaving the K-wire in place. Mount the cannulated drill bit over the K-wire and drill the tunnel. Hip dislocation and visual control of the intra-articular space help avoid cartilage and acetabular cortex damage. After drilling, clear the tunnel entrance of soft tissue and bone debris and thoroughly rinse the tunnel from the fovea capitis toward the greater trochanter to remove bone fragments that could damage the implant fibers. To drill the femoral fixation tunnel, make a small incision on the caudal aspect of the femur to access the bone. Place a Hohmann retractor between the femur and the soft tissues to protect the sciatic nerve during drilling. Proceed gently. Internally rotate the limb to facilitate caudocranial drilling at the center of the femur to reduce the risk of fracture. If access to the caudocranial axis is insufficient, a more lateromedial drilling axis may be used. First, place a threaded K-wire 5 mm distal to the exit of the passage tunnel. Then mount a cannulated drill bit over the K-wire and drill the tunnel. Clear both tunnel entrances of soft tissue and bone debris, blunt the edges of the tunnel entrances and rinse thoroughly, including inside the tunnel. The fixation tunnel must be compacted using an interference screw. Alternatively, the tunnel may be tapped with a tap. For tunnel compaction, as shown here, measure the fixation tunnel to select the appropriate interference screw for implant fixation. Compact the tunnel using the selected screw, guided along the tunnel axis by a blunt K-wire and inserted with a cannulated ratchet screwdriver. Advance the screw until it is flush with the bone. Bicortical placement improves fixation strength. Slow the insertion when increased resistance is encountered at the cortical bone of the tunnel exit to avoid transcortical fracture. Remove the screw and K-wire, then flush the tunnel thoroughly. For acetabular tunnel drilling, rotate the limb until the patella faces upward and slightly extend the hip to expose the acetabulum. Place a threaded K-wire at the center of the acetabular fossa corresponding to the ligament footprint while avoiding damage to the femoral head and the crescent-shaped cartilage. Stop advancing the K-wire at the acetabular exit to prevent injury to surrounding soft tissues, including the colon. If perpendicular access is limited, a cranially oriented trajectory may be used. Drill with a 4 mm cannulated drill bit mounted over the K-wire to allow passage of the cortical button and rinse the tunnel thoroughly. The surgical site is ready for implantation of the prosthesis. With the forceps, insert the cortical button into the tunnel, push it through, and sit it on the medial side of the acetabulum by pulling on the implant. Proper fixation allows the animal to be lifted by traction on the implant. To pass the implant through the femoral passage tunnel, insert a wire loop from lateral to intra-articular to pull the implant leader thread through the tunnel. Compact the implant traction cone with forceps to facilitate its passage, then pull the leader thread to pass the implant and reduce the hip. Maintain visual control during passage to confirm that the implant advances centrally within the tunnel, preventing contact with the cortical bone. To pass the implant through the femoral fixation tunnel, insert a wire loop from cranial to caudal to pull the leader thread through the tunnel. Then pull the implant, keeping it flat and untwisted. Once the implant is in place, apply pressure to the greater trochanter to reduce the hip. Adjust tension between the femoral tunnels with a curved clamp while pulling the implant at the cranial exit of the fixation tunnel with a needle holder. Then roll the implant around the needle holder and release trochanter pressure. Insert a blunt K-wire opposite the implant in the fixation tunnel, avoiding crossing or twisting the prosthesis. Then lock the implant with a caudocranial interference screw inserted as previously described, ensuring proper engagement using counter support to prevent implant shearing. Assess joint congruence and full range of motion. Tension must maintain hip reduction while allowing for a full range of motion, including flexion, extension, abduction, adduction, and internal and external rotations. If tension is insufficient, retension and reinsert the screw. This can be performed only once. If still inadequate, use a larger screw and confirm implant integrity. Trim excess implant and flush thoroughly. Close routinely to complete the procedure. This 3D animation shows the final form of the reconstruction, detailing the trajectory of the synthetic implant and the position of the fixation points. Surgical treatment is chosen based on the type of luxation. This technique addresses craniodorsal, caudodorsal, and caudoventral luxation, providing immediate hip stability and motion without postoperative immobilization, allowing early limb use. TEP-style implants are expected to better limit reluxation and the cheese wiring effect compared to traditional suture-based implants. The fixation by an interference screw embedded in the bone avoids soft tissue irritation that may arise with nut or eyelet anchor fixation. It eliminates the need for nuts, which may slip when using ultra-high molecular weight polyethylene sutures, and facilitate appropriate implant tensioning during fixation. Strict rest for 6 weeks is recommended, which is shorter than with other techniques. In high-risk or revision cases, apply local antiseptic and collect samples for bacteriological analysis. This video covers all steps of the procedure, but proper training is advised to learn the critical details that ensure a safe implantation. This procedure is generally safe, but complications may arise, each with identifiable causes and solutions. Thank you for watching this video. We hope that this technique will help you in the future.